4 minutes late, so we're starting a minute early. Before we get started, I want to recognize our Sergeant at Arms from the Senate, Gary Bridges, Tracy Carr, Michael Norton, and Keith Whitfield. Thank you all for being here today. And from the House, Michael Galloway, Thomas Terry, and Stafford Young. I appreciate it. We have a full agenda, so I am going to try and do the best I possibly can, and I appreciate everybody being here today. We're going to cover a lot of great different topics. First, I'm going to turn things over to my friend, Secretary Sangvai. Thank you for being here today.
Thank you. Thank you, Mr. Chairman. Thank you, committee, for your time and attention to these important matters. This afternoon, we'll be covering several issues that are critical to the health and well-being of North Carolinians. First, we'll provide an update on Medicaid, including enrollment and the program's financial outlook for the remainder of the fiscal year. As you know, Medicaid serves more than 3 million people across the state. The key takeaway from this update is that overall spending in the program is tracking very closely with the projections the department shared with you previously. We still need $319 million before the year end for Medicaid rebase. We will also provide an update on the Children and Family Specialty Plan. While we are only about 3 months into implementation, it is already an important step in better coordinating care and services for children involved in our child welfare system. With that, we will begin with our Medicaid enrollment and financial update.
Thank you, Mr. Secretary. And I'll turn it back over to you. And I guess newly appointed, I said congratulations to Melanie earlier, maybe condolences, I'm not sure which, but excited to hear from you today and look forward to your presentation.
Thank you, Senator Sawrey, and thank you, members of committee, for having us here this afternoon. I am Melanie Bush. I'm the Interim Deputy Secretary for North Carolina Medicaid, and I'm here with Chris Gordon, our Chief Financial Officer, and we're going to provide the Medicaid enrollment and financial update as of March 2026. There's a lot of big numbers in this deck, and so before we get started talking about all the big numbers, I want to start talking about who actually receives these services and what these big numbers pay for. So, next slide. 1 out of every 4 North Carolinians in North Carolina receive some sort of health care coverage through the North Carolina Medicaid program. It is not comprehensive coverage in every case, but by and large it is. Some people receive a limited benefit through family planning. Some people only receive coverage of their Medicare premiums because they are dually eligible for Medicare and Medicaid. But 1 out of every 4 North Carolinians receive support from the Medicaid program. We have a disproportionate number of children that rely on Medicaid for their health care services, and a disproportionate number of people with disabilities, because North Carolina Medicaid covers long-term services and supports that Medicare and commercial insurance normally do not cover. And so we see high enrollees there. This breakdown of who's eligible for Medicaid is important, I think, when we're talking about the rebase. I think it's important when we're talking about the rebase that we fully understand that the Medicaid expansion population is funded 100% by the federal government and hospital assessments and not general fund dollars. So what we're talking about when we're talking about the rebase are all the people on the left-hand column. This is your traditional Medicaid program. These are seniors, these are people with disabilities, people who are blind, deaf, hard of hearing. These are our dual eligibles, and these are our children, foster children, and people receiving the limited family planning benefit. And so when we're talking about curbing costs in the rebase, the services for this population on the left-hand side is what we're talking about. And then finally, I just like to occasionally remind people of the income eligibility limits for Medicaid. I think sometimes we talk in percentages and people don't really have good concrete numbers about the actual annual income that is required to qualify for Medicaid. So for example, for Medicaid expansion, you can earn $20,000 and still be a family of 1 and eligible for expansion. However, if you're an adult age 65 and you're a family of 1, you have to have income less than $15,000 a year. If you are a grandparent taking care of a grandchild and you have a family of 2, your income cannot exceed $20,000 a year. And so there are very restrictive limits on traditional Medicaid. The expansion is a little bit more broad. So here we have our actual enrollment trends. You can see this is for non-expansion only. We'll talk about expansion in just a second. You can see that We had an increase starting with the beginning of the pandemic, and we had continuous coverage, and it reached its apex in July of 2023. And then we started the unwinding, and as predicted, we are seeing a steady decline in the overall non-expansion population. And you can see where we are as of right now and where we are projected to go. We do expect it to continue to decline. We don't expect to return to pre-pandemic levels in the program simply because of changes in population overall statewide. Our Medicaid expansion enrollment looks a little different. Since we started in December of 22, you can see that there has been a steady climb, but we are reaching a plateau finally, several years in. We're at about 722,000 North Carolinians that have coverage through Medicaid expansion, and we anticipate, barring any other economic downturns, that will plateau and remain flat going forward. So when we're talking about the rebase, I want folks to also have a precise understanding of what we're really talking about. The rebase, we have a base budget in Medicaid, and the rebase is really the adjustments to the prior year's base budget that account for enrollment, utilization, and medical inflation. Of those three things, I want to point out that we really have no control over enrollment. That's economically driven. We don't have a lot of control over medical inflation, but we try, and we have lots of tools to keep that as low as possible in the Medicaid program. We do have a certain amount of control over utilization, and we pay our health plans to do utilization management, and we conduct utilization management for the Medicaid Direct program. On top of that, this year, and we'll walk through what's in the rebase, there's always an adjustment for these three things so that we can continue to pay for the same population, the same amount of services. But this year, and years past too, there's often one-off asks that we have, that we need funding for, that we've included in our rebase ask. We do work closely with the Office of State Budget Management and with Fiscal Research to work on what we think that rebase number is. We don't always agree on what that number is, but we always try to agree on what the inputs are. So this slide, I think, is important to understand that while almost 80% of our enrollees in the Medicaid program are families and children, they account for less than half of our total expenditures. What is driving the Medicaid rebase budget are the 21% of older adults and people with disabilities that account for more than 54% of our expenditures. And you can see how they're mapped here. And that makes sense because families and children are generally healthier and they are generally lower cost. People who are older and people who have disabilities are usually more medically complex and require long-term services and supports that are quite intensive and resource heavy. So this is what we have been referring to internally as the Jell-O chart because it looks like different layers of Jell-O on top of each other. But you can see here at the bottom, the medical cost inflation, changes to service utilization and enrollment. That is what the rebase generally is. And you can see that for this year, we have requested $368 million. That accounts for about 45% of the total rebase ask. Again, of those three factors, we really only have input and control over utilization and medical inflation to a degree. The rest of the rebase are actually things that are outside of North Carolina Medicaid's control. So we have $200 million of recurring expenditures that have been funded on a non-recurring basis. And so we have to ask for that funding to cover our recurring costs in our rebase. And we understand that some things are funded on a non-recurring basis depending on what fiscal year we're in, but we still have $200 million worth of recurring costs that we need to account for. We also have a reduced federal funding match. So North Carolina per capita is getting wealthier as a state. And so the federal government then reduces the amount of federal match they give us depending on the income per capita. And they revise this rate every single year. Last year we saw it decrease. This year it is decreasing, and we expect it to decrease again in October because North Carolina is doing economically well. What that means, though, is that with the offset of federal funds, it does require more general funds. We also saw a change in federal match for tailored care management. That was an enhanced rate for 2 years, and unfortunately expires this year, and we need to make up the difference for that. Because there are a certain number of weeks in this year, we actually have an extra check rate, and our check rate is when we pay our bills. And so because of the number of weeks that are in this year, we have an extra check rate, and that is another $40 million that we have to account for. And then finally, we launched the Children and Family Specialty Plan on December 1st, and that is part of a bigger child welfare reform, and we didn't feel that we could undermine the bigger child welfare efforts that the department and the General Assembly have agreed upon, and so we launched that plan, and that was another $40 million as part of our rebase. So that's what the rebase looks like. This represents the $319 million that we'll talk about later. This is just simply to show what I mentioned earlier about the federal match. You can see that in fiscal year 2025, we spent $28.9 billion. Of that, 19.2 was federal match and 6.1 was state dollars. This year, we're actually expecting to spend less than last year due to the decrease in enrollment that we mentioned earlier. But because the federal match has reduced, we're only getting $17.9 million in federal receipts. And so that means that we have to make up the difference with the general fund, $6.7 billion. So where we are is $319 million. That remains our ask. I think we have been watching our budget very closely. You will see that our actuals are very close to the projected forecast. And we anticipate that we will run out of funding before the end of this fiscal year. So we are asking the General Assembly to please take action on the rebase as soon as possible to prevent the uncertainty that we experienced in the fall with rate reductions. Our provider community, and most especially our beneficiaries, want to make sure that they have access to the care that they need. Excuse me. This is our actuals. The dark line, the dotted gray line, is our forecast, and you can see where we are right now. Out of our $6.4 billion appropriation, we've spent $3.9 billion through the end of January. We do anticipate running out of funds starting in April and May. There's a difference between running out of funds and being unable to pay our bills. We would like to pay our bills too, and so that's why we really are asking the General Assembly to move as quickly as possible to get that funding in place. Okay, so I've just talked a lot about where we are. And I understand that $319 million is a lot of money. And I understand that the North Carolina General Assembly has many other priorities. I have children in North Carolina public schools, for example, and that's a big priority of mine as well. So I want to spend the next couple of minutes talking about what we are doing at the Medicaid program to keep costs controlled. We don't necessarily always show our work. And so this is my attempt to show you what we do on an annual basis without any legislative directive to keep costs within check. We heard this fall from the National Conference of State Legislatures about different ways that different states balance their Medicaid budget, and we have tried all of them, and we continue to try all of them. But most of our efforts fall into three major buckets: cost avoidance, targeted intervention, and long-term strategies. And cost avoidance is simply just making sure that the expenditure never happens. And we do that in a number of ways that I'll talk about in a minute. Our targeted interventions are more short-term things like rate reductions or service eliminations, operational cuts that we can make. And then long-term strategies are generally things that we do that aren't necessarily going to realize savings immediately, but they will in the long term. That doesn't necessarily work in a 2-year budget cycle, and sometimes these things require upfront investment to get long-term savings. And so we're trying to do a combination of all three all the time in the Medicaid program. So when talking about cost avoidance, I do have to give a big shout out to our pharmacy team at the North Carolina Medicaid program. We have a very robust pharmaceutical cost control. As you all know, the cost of drugs is astounding in the United States. And our team does an amazing job of getting us the best return on our investment for these drugs. We have a single statewide preferred drug list that all of our health plans have to use. Because all of our health plans have to use this, and we manage the preferred drug list and we manage what the rebates are, all of these rebates come back to the state. They do not go into the coffers of our health plans. They come back to the state to offset the cost of the Medicaid program. And on average, for every dollar that we spend in the Medicaid program on prescription drugs, we get back 55 cents. So that's a pretty good rate of return. And in addition to federal rebates and supplemental rebates that we get as part of a consortium of states, our pharmacy team has also been able to negotiate additional rebates with manufacturers directly to have specific rebates come to the North Carolina Medicaid program only. And last year we achieved $2.3 billion in rebates through those negotiations. So right there, we're preventing those costs from taking place. We're also doing program integrity and fraud, waste, and abuse detection and recovery efforts. We're also doing clinical initiatives that increase health outcomes and prevent more costly care. All three of those things are then baked into our capitation rates, right? So we're taking off the top certain assumptions every year, and we're saying, okay, these are our capitation rates for our health plans. We assume that you're going to have X amount for savings for pharmacy, X amount for program integrity, X amount for clinical coverage. And okay, so these are baked into our capitation rates, and that's what we mean by managed care optimization. We bake in some of these efficiencies from before we even pay them out. In terms of targeted interventions, I do want to talk about this briefly. This year, because we did not get our full administrative budget, we were required to cut $139 million in total contract reductions. Of that was $57 million in state funds. And we did that through vendor management and scope refinement. But we also had to delay some implementations, and we had to stop some oversight. We basically went through our entire list of contracts and determined what was federally required, what was legislatively required, and what was discretionary. And anything that wasn't federally or legislatively required was considered discretionary, and we made adjustments to every single one of those contract line items. And so you can see that we came up with $57 million in state savings. Another thing we do is enhance third-party liability. So in the Medicaid program, you can actually have other insurance. You can have Medicare, you can have private Blue Cross insurance, for example. That is fine, but Medicaid has to be the payer of last resort. So we often have third-party liabilities, making sure that the primary insurance pays first, or in the case of, like, for example, a car accident, the other person's insurance would have to pay that liability first. We pay our health plans to do third-party liability recoveries, and they do a great job, but we do take an extra pass after the end of the year, and we are projected to achieve about $40 million in come-behind savings that weren't identified by the health plans. And then, of course, we are, because our federal match is changing this year, we have a plan to make a payment before our federal match changes so that we can optimize the federal rate, and that will save us about $8 million. So we're looking to pick up every penny we can, basically where we can, because we know that there is so much money involved in this program. And then finally, we're talking about long-term strategies for consideration. We have value-based infrastructure that we work on. You know, you all have heard extensively about our Healthy Opportunities pilots. Those sometimes require upfront investments. I understand we're not in that situation right now that we can do those kinds of things, but those are proven to bend the cost curve in the long term with a little bit of investment up front. We're also doing future procurements, we are actually on the verge of merging 2 health plans, so we anticipate that we'll have some optimization there with overhead. And then we are using all of our performance plans. We have withholds for our contracts. We have medical loss ratio requirements for our health plans to hold them accountable. And then we are using AI. Everybody is these days. I don't think you can go anywhere without hearing about AI. And we're trying to use AI to leverage advanced analytics and program integrity. Okay. So this is the last slide. I know you're all relieved, just like I am. But I did want to point this out. We presented this slide back in October. And I think that it is illustrative of what I've just been talking about. North Carolina's Medicaid capitation rates are below the national average. And it's because we're doing all of the things I just talked about: the cost avoidance, the targeted interventions, and the long-term strategies. We take our responsibility for fiscal stewardship very seriously at the Medicaid program. We understand it is a huge number. We understand that you have other priorities. And we just wanted to demonstrate what we have done to date. So with that, I will stop talking and answer any questions you may have.
Thank you, Deputy Secretary. Big topic that's going to drive a lot of our conversations over the next couple months. I appreciate the detailed presentation on it. A lot of us have several questions. I'm going to start with 2 for you. When discussing obviously some of the differences between the legislature's projections and yours, we received some information that one of the deltas was a result of a decrease in hospital receipts on the provider assessment. I understand that's about $93 million, which is concerning. Have you or anybody at the department looked into why those receipts are down, what's causing that, and how we can be more prepared for that in the future if that comes up and projected better?
Thank you for that question, Chairman Sawrey. We don't have that data that shows that difference because we have different numbers than fiscal research does, but we are happy to look into it and have that conversation.
Thank you. Second question is, I think the largest bucket on your Jello chart talked about, I think prescription drug costs were in there, of course. Was that lumped in the bottom portion?
Yes.
Okay. When we had the initial conversations, GLP-1 drugs were a large line item, of course. The GLP-1 drugs, I think at the time were, I'm going to use a round number here, about $500 per month after rebates. I understand there have been negotiations now down, so they're actually oral GLP-1s that are 80% less than what the initial cost is. Is that baked into this as well, or have these numbers been updated to reflect that decreased cost? Where do you stand on that?
They are not baked into this rebase request, but they are going to be baked into the going forward rebase request. We have had individual conversations with the makers of GLP-1s to give North Carolina an additional savings. I will say that to date, we have spent about $3 million total state dollars on GLP-1s since the beginning of the fiscal year.
Thank you. Turn it over to questions from the committee. Senator Robinson.
Thank you, Mr. Chair. You mentioned that we may have some reduction in the federal funding. So what impact would that have? Give me an example of services.
So it won't have an individual, thank you for the question, Senator Robinson, sorry, be recognized. It won't have an individual impact on a specific service. It really is just decreasing the number of federal dollars we have to pay for the overall program. So you can see that it goes from 19 to 17. Those are the federal dollars going down. And so you can see that at the same time, our state dollars are increasing from 6.1 to 6.7. So it's going to require more general fund. And that's a problem, right, when you're limited resources at this time, because the federal government is pulling back its investment in North Carolina Medicaid.
Okay, follow up. One of the other questions I have is, you mentioned the savings, different places. So you mentioned capitation. I don't quite understand how you apply those savings.
You're recognized.
Thank you, Chairman. That's a great question, Senator Robinson. So what happens in managed care is that every year the health plans are paying for the services for their members that are in their network. And at the end of the year, we look at their expenditures and we use that information to set rates for next year, right? And so we base that off of what they see in terms of utilization, what they're seeing in terms of inflation, what they're seeing in terms of enrollment. But then on top of that, we're baking in some savings that we have realized. So those pharmacy savings that our team is working on behind the scenes, we assume some of that comes out of their rate. Program integrity recoveries, we assume some of that comes out of their rate. And so that's how we bake it into the capitation payment on the front end. And so every year at the end of the year, we're doing sort of a reconciliation of those costs.
Okay, thank you.
Representative Ryan, recognized for a question.
Thank you, Mr. Chairman. So you mentioned the federal dollars coming down are reduced because North Carolina is doing better economically. And you said you don't have control over enrollment, but that's based on economics. It would stand to reason that as the economy is better in North Carolina, that less people would be on Medicaid. And on slide 5, in our traditional Medicaid enrollment, it does look to be decreasing. So are more people, are people just more costly problems that they have because it's decreased enrollment? So are the ailments cost more, or what's causing that?
Thank you for that question. Thank you. That's a great question. It's something that we've tried to look at internally as well. So our decrease in enrollment is reflective of the fact that we no longer have continuous coverage that was required during the pandemic. So it's not necessarily that people are moving off of Medicaid. It's just simply that they're either eventually aging out or just moving even to expansion if their income is increasing in any way. We are seeing that the expansion population is remaining very flat. And so what it really means is, I think per capita, our economy is doing great, but there's still a class that needs health insurance, and the opportunity for them to move up is people are using the opportunity of Medicaid expansion to move on to private insurance. I think it's just a stair step, and that's not being impacted by the economy. The people that are on our traditional Medicaid program are your aged, blind, disabled people and your children, and those aren't the ones that are normally motivated by an economic force in terms of changing their income.
Follow up.
So, but you show those decreased enrollments for that age group, for the traditional are they experiencing costlier services that's driving up this cost with this decreased enrollment? And what are those services that seem to be spiking or that are driving up the cost?
I'm sorry, I misunderstood your question,
Sorry.
Representative Ryan. I apologize. Yes.
Yeah.
Chairman, sorry, thank you.
Yeah.
I'm very bad at this.
No, you're doing great. Easy topic for your first committee, right?
So you can see on this chart here that we have 80% of our population is family and children, and they only account for 48% of our expenditures. So people who are older and people who are disabled have more complex services. They require in-home services. They require long-term care services. They have multiple chronic conditions. They require lots of high-cost medical interventions. And so they are the more expensive population, yes. And so the services, and on top of that, just medical inflation in the United States is contributing to those increased costs.
Representative Cunningham.
Thank you, Mr. Chair. Deputy Secretary, on slide 13, one of the things that say identify the cost drivers, it's got costs, commissions, studies, task forces. Is those also the ones that the governor get to appoint, the legislator get to appoint? Are those all of those?
Thank you for your question, Representative Cunningham. This is a slide of what other states have done to retain their costs. And other states have looked at, task force about like how to reform the Medicaid program or how to balance the state budget. I know that those efforts are going on nationally because everyone is experiencing some level of purse tightening around the country. And so that's just something, there's not an existing task force or an existing commission, but it is something that the legislature or the governor could appoint.
Follow-up.
Follow-up question.
Thank you. On page 15, if you look at the revised skilled nursing facility admission criteria, can you go into a little depth about that? And also, can you answer the question for how many years does it require for an individual to relieve assets before they can qualify for long-term skilled care and Medicaid cover it? Thank you.
Sorry. Great questions, Representative Cunningham. So to answer your second question first, Medicaid does have a 5-year look-back period for any assets. And so if those assets are in your possession within those 5 years, you could have to pay a penalty. Generally, people have been able to transfer those assets and they're not counted towards their long-term care. But if they are within that 5-year period, they're subject to a penalty for the long-term care. What we mean here about revised skilled nursing facility admission criteria, this is a joint effort that we've had with our health plans and with our hospital systems. We experienced difficulty when we launched managed care about having individuals discharged from hospital settings to skilled nursing facilities because of the payment structure. And we went back and forth with the health plans, and they assured us that we were not doing it correctly. And we went to the Centers for Medicare and Medicaid Services, and they assured us that we were doing it correctly. And long story short, several years later, we finally came to see eye to eye and understood what we were talking past each other. And we got permission from CMS to change our enrollment criteria. So what that means is that we can pay our skilled nursing facilities prior to the establishment of a PML, patient medical liability. And in that way, it guarantees payment to the facilities, and everybody is willing then to have these folks admitted from the hospital.
Senator Adcock.
Thank you, Mr. Chair. Thank you, Secretary. I wanted to talk about your Jello slide a minute. That's the best I've ever heard why we need rebase money. You did a really good job on that, so give yourself some credit for that. My question is, when you said, I just want to understand this, you said there's a difference between running out of funds and being able to pay our bills. And as we think about how critical it is to get this $319 million remainder of the rebase money done as soon as possible, would you explain that to me? Maybe I'm the only one that doesn't understand the nuance in that. Thank you very much.
Thank you, Senator Adcock. So that's a great question, and it is a fine distinction. But as you all know, we spend hundreds of millions of dollars every month on, for example, capitation payments alone. So there will come a point where we may have a couple $100 million, but we don't have enough to pay all of our health plans, or we don't have enough to pay all of our vendors. And that's what I mean by not having enough to pay our bills.
Follow up. So what you mean is insufficient money to cover
That's
the
correct.
whole tab. Thank you very much.
Thank you. Senator Bergen.
Thank you, Mr. Chairman, and thank you for being here. This is your first, and I hope you'll walk away and say it was a good visit. So I'm enjoying it, and I've enjoyed talking to you. Could you? I know you probably don't have this, but every year I always ask for the top 10 Medicaid, the top 10 most expensive cases. And the last time I looked at it, the top 2 were both gene therapy treatments. Could your folks get that together and send it to everybody, or send it to the chair and he'll send it out to everybody?
Absolutely.
And then just recap for me, just your top 3 drivers of cost this last year. These rebases, we've got to get a hold of that. We can't keep doing that. And with the projected one for the 26-27 being significant, we've got to make some adjustments somehow. Would you just kind of walk through those top 3 and then tell me what the department's looking at doing or what we need to do, because some of the things probably we're going to have to do legislation to deal with. Would you mind walking through those, please?
Deputy Secretary.
Thank you, Senator Bergen. So I will just say that's a two-part question, and I'll answer it in two parts. Number one, our rebase, the top three drivers, are the inflation, service utilization, and enrollment piece. The fact that we have recurring funds that are funded on a non-recurring basis, and the fact that the federal match is decreasing. Those are the biggest three chunks of our rebase ask. But I think the question you're asking is, within that medical cost inflation and service utilization, what are the three drivers? There we can see that we have something we'll talk about later today. Research-based behavioral health therapy is a big driver. We've also seen an increase in 1915I services for individuals who are waiting for an innovations waiver slot. And then, of course, prescription drugs is a huge driver. Even though we do get significant rebates on our prescription drugs, the cost of prescription drugs continues to climb.
Follow up.
Thank you, Mr. Chairman. Talk to me a little bit about fraud, waste, and abuse. That's a big topic. We had the state auditor at the first meeting talking about it. Tell me what the department is doing, what AI you're using to help look at outliers, and just kind of walk us through what you're doing about that.
Deputy Secretary.
Thank you, Thank you, Senator Bergen. We have a robust fraud, waste, and abuse program, as you can imagine, with the amount of money that we are responsible for. We are subject to federal audits, Office of Inspector General audits, General Accounting Office audits, OMB audits. We have a number of federal audits that we're subject to every year. Of course, we have the Office of State Auditor, who does a single state audit does Medicaid audits every single year. We also have our Office of Internal Audit at the department that also conducts audits on a annual basis. And so we are constantly looking for outliers. We are constantly looking for findings and opportunities to strengthen our fraud, waste, and abuse protocols. There are a number of different things that people can do. We've heard a lot of concern about fraud, waste, and abuse in service providers. If a health plan, we pay our health plans to do utilization management. If a health plan determines that some provider is billing outside in an outlier type of way, the health plans have tools in their toolbox that they can use to rein that utilization in. They can put that individual on post-payment review so that they can go behind all of their claims and make sure that they're medically necessary. If they don't want to chase the dollars, then they can put them on prepayment review, which is looking at every single time they bill, looking at whether that is appropriately billed and is medically necessary. We often do refer cases to the North Carolina Department of Justice Medicaid Investigative Unit for fraud when we think that there could be potentially criminal fraud involved, and those are handled by NCDOJ. We also have a master service agreement now that we are using to procure AI tools to run against our claims and encounters to identify any outliers that we have missed anywhere else. The health plans are using these tools. We are using these tools internally. I think that there's lots of opportunity with AI to do tons of analysis, but we are just getting our hands around it at this point.
We've got just a few more minutes. Senator Heiss has got questions. Senator Heiss.
Thank you, Mr. Chairman. Two areas I want to look at. First is on slide 5 that's looking at this non-expansion enrollment trends. We went through 3 years. The federal government didn't even let us assess anyone who was on, wouldn't even let us start the process till the 3 years was up. Then we staggered the process and we didn't do children, we didn't do to come in. But now that I think everything's back online, it is not dropping at the rate it increased. That's with coming in. And I really want to look into compared to other states, because this is not the story I'm hearing from other legislators across the country. I mean, we're still up almost 10% in this, probably from the start of the pandemic, of non-expansion enrollments, and we added expansion in the midst of that process, and I think other states are seeing a lot more people come off this process once they started doing the verifications again. So I really want to ask the question, what's different for us in that process, and why are we seeing a more flatlined approach since we finally started all those?
Deputy Secretary.
Thank you, Chairman Sawrey. Great questions, Senator Heiss. What we're seeing is, first of all, North Carolina's overall population increase is growing. And so we're not going to go back to pre-pandemic levels just because the state is a wonderful place to live, and people are moving here, and people are retiring here, and people are eventually qualifying for services here. So that's one thing that is happening in North Carolina that isn't necessarily happening in other states. The other thing is something that you mentioned, which is we launched expansion during the middle of our unwinding. And so a lot of the people that used to be on this line are now on the expansion line. So they're still on the overall Medicaid enrollment, but you're not seeing them on this line decrease. Another thing that is happening here is children are aging out of care and they're moving on to expansion. And so some of these are children and they're just on the program for a longer time until they actually age out into the expansion population. So those are the three things that I would point to, but I know that in other states, they had different approaches to the unwinding. I think that we actually did a really good job of making sure that people understood what was happening and making sure that the people that are eligible for the program remain eligible, and the people that are not eligible for the program have fallen off.
Follow up.
And then follow up, I wanted to ask on 9, that's kind of showing this change here. There's specifically 2 areas: the one-time check rate that's in the red, and the replacement of non-recurring funding with recurring funding. Do you have any indication that those things have ever been part of rebase before? I mean, if you have a one-time check rate this time, we fund it under rebase, well, then that becomes part of the base budget for next year when you don't have another check rate that's what coming in. And generally, when things are funded non-recurring, it's a policy decision whether you want to continue the program beyond the time the program has been funded, and not an actual rebase discussion about those type of the continuation fundings of the program as existing.
Deputy Secretary.
Thank you, Chairman. You're absolutely right. And I think in years past, we have never been operating on such a thin margin that we would have to ask for these types of funds in our rebase request. I think in years past, we had, more federal dollars coming in. We were able to manage the shortfall in funding that we've had appropriated to the North Carolina Medicaid program. But because it's such a thin margin this year that we have to include every single thing in the kitchen sink into our rebase to make sure that we are able to pay our bills. And so you'll see things like one-time check rate or non-recurring funding. We do have a lot of recurring funding items that are funded on a non-recurring basis that aren't optional. And that's what this request is for. These are ongoing services and ongoing requirements for the federal operation of this program. Things like vendor contracts that are funded on a non-recurring basis. We cannot run a Medicaid managed care program without an enrollment broker, and that has been funded on a non-recurring basis. So those are the types of things that have traditionally been funded non-recurring that are recurring costs. And then because we have so little wiggle room in our budget and so little extra money, we have put everything on the list.
Vice Chair Gately.
But just let me follow up.
Okay,
with this.
sorry, follow up.
There's a lot, I assume there's also a lot of requests from the department that aren't a rebase discussion. When we do an entire budget, there's others there, and there's a lot of things like Healthy Opportunities Pilot that we were approved through CMS that was funded non-recurring.
That's right.
That ended because it was funded non-recurring, but we had approval from CMS to expand statewide in those kind of operations. So I'm just trying to get this to the statutory decisions of what we do in rebase versus what are budget and policy decisions that are ultimately made.
Deputy Secretary.
I fully understand your point, Senator Heiss, and it's completely valid. I think what we're talking about here in terms of non-recurring funding are vendors that have historically been funded. The Medicaid Transformation Fund, for example, that funds part of our claims processing system. It funds our enrollment broker. It funds our EQRO, which is an evaluation thing that is required by the federal government. Those things have been funded on a non-recurring basis, and those are required by federal law for us to operate managed care. So in many cases, yes, you can determine whether or not to end something and sunset something by putting it on a non-recurring basis, but I think this was just a structural budget issue that we're trying to fix.
Thank you. Vice Chair. Kerri.
Thank you. There was a report about the state savings from Medicaid expansion that was due starting in February 1st to 2025. I don't think that we've ever gotten any of that report done. I believe that the legislature asked about that in January. Why, if that report has not been submitted, why hasn't it been, and when will it be released?
Deputy Secretary.
Thank you for that question, Senator Gailey. Yes, you all, actually Chairman Sawrey asked about that at our last JLOC, and I said that we would get it to you very shortly. It was still under review. It has finally come to me for review, and I did not feel comfortable releasing it to the General Assembly until I've had the opportunity to fully vet it, because it's going to go out under my name. You shall have it very soon, I promise.
Follow up. Co-Chair White, any questions? Representative Cunningham.
Thank you. I'm gonna go back to slide 13 again.
And Representative Cunningham, we're gonna let this be the last question, okay?
Thank you. So as I was looking at slide 13, and they talk about the Medicaid cost drivers, and I went down to balancing the Medicaid budgets, and you were saying that other states were doing some of these things. Have you all looked at those options down there for us to look at possibility of savings? And the reason I brought it up about the commissions, because sometimes it seems to be duplications of things that are going on. And that is one that's identified by the NCSL. Have you all done that?
Deputy Secretary.
Yes, thank you. Yes, we have. We've explored all of these options. We have tried to reduce the size of our contracts. We have tried to improve overall outcomes through our clinical policies. We have enhanced our oversight and evaluation. And we have tried to maximize federal revenues to the extent possible. But as I mentioned before, because of the economic situation in North Carolina, that is actually decreasing. So yes, we continue to look at all of these options. We know that there's a bigger conversation for next year that needs to happen, where we can revisit these options again, and we look forward to having that conversation.
Thank you, Deputy Secretary. Appreciate that. This is going to be a big topic, obviously, over the next several weeks. We're going to talk about it again later in the agenda with the ABA therapy, but I do want to turn it over to Deputy Secretary Leighs and maybe Deputy Secretary Bush as well to talk and update on the Children and Family Specialty Plan implementation. Deputy Secretary Leighs, you're recognized.
Thanks so much, Mr. Chairman and members of the committee. Really appreciate the opportunity to be with you this afternoon and share an update on the Children and Family Specialty Plan. As you mentioned, I'll be starting this presentation, then handing it over to Melanie. Just a bit of background. So my title is Deputy Secretary of Opportunity and Wellbeing, which includes oversight for our Division of Social Services and Child Welfare Services, and really want to just emphasize this joint effort between my team's work and that of North Carolina Medicaid. So I want to place this important CFSP program in the context of our broader efforts to strengthen child welfare in the state. And you'll see several initiatives up there that I do want to pause and just acknowledge the tremendous support from the General Assembly for these initiatives. We're incredibly excited about what you see here. That includes Path NC, which is our child welfare information system, which is now live in 89 counties. The support for kinship caregivers has driven that number up, where almost 1 in 3 children in foster care is now placed with relatives. And of course, the bipartisan support for the Fostering Care Act, which was passed last spring, which is will implement significant systems reforms in our child welfare system. Thank you again for that support. Now, this next slide has several of the key items that are key components of the CFSP program. And so, as you know, this supports children and young adults who are receiving child welfare services or have previously received child welfare services. And Healthy Blue Care Together, who you'll be hearing from shortly, is administering the plan, which launched on December 1. So instead of going through each of these components, one of the things I wanted to do, with your permission, is just to talk a little bit, one of the key components here around permanency that really is a nice link to our efforts around child welfare reform. I'd love to do that with an example. And so I want to consider, this is not, of course, a real case, but let's consider John, who enters foster care due to neglect. Now, reunification with John's biological parents is not safe, so placement with relatives is the next best option. Now, John's grandmother wants to say yes, but she's worried about whether she can realistically meet his unique needs. She works full-time, she has 3 other children in care, and she's planning a move across the state later this year. Now, John has a chronic medical condition that requires consistent specialty care, and like many children who've experienced abuse or neglect, he also needs trauma-informed behavioral health services. Now, John's grandmother is worried she can't handle the logistical burden of coordinating the care. But without the care he needs, there's a higher risk of John's placement falling through because he doesn't have the support to transition successfully to his new home. This is where the CFSP makes a huge difference. Through Healthy Blue Care Together, John is assigned a dedicated care manager, a brand new resource now provided to all children enrolled in CFSP. John's care manager coordinates his medical and behavioral health care, secures referrals, schedules appointments, and ensures continuity of care no matter where his family lives across the state. So for John, this difference is life-changing. Because the system is working better, his grandmother is able to say yes, and he finds a stable, loving home with the wraparound support he needs to heal and thrive. While we have much more work ahead in implementing this plan, I just wanted to share this example to demonstrate the full potential of the CFSP and why it is such an important part of our work to transform child welfare in North Carolina. Now, as we look to the future, as you'll see on the final bullet point, we are looking to expand this to focus on whole family support and treatment and well-being as the next phase. I'd like to hand it back over to Melanie to talk a little bit about the implementation to date.
Thank you. Deputy Secretary Bush.
So you've seen our timelines before for our managed care launches. This is a simpler one because it is one health plan, but I wanted to use this opportunity to talk about the fact that what is unique about the Child and Family Specialty Plan is that we are dealing with all of our county divisions of social services, child welfare offices. So those are the other partner. In the past, we've had a health plan readiness and we've had our departmental readiness. In this case, we actually did county readiness because we are changing operations, we are changing how they manage children in the county DSSs. And so I wanted to just sort of use this slide to highlight that we have been working very closely with our county partners. Healthy Blue Care Together has been working very closely with our county partners. We are hearing constantly feedback from the counties about how this implementation is going. And we were able to do all of this work within 15 months. All of our successful managed care launches require successful stakeholder engagement. We've worked closely with all of our counties. As I mentioned, day one readiness, everyone knew who to call Parents and beneficiaries had cards in hand, they had welcome packets. The county DSS staff were able to access information about their children through our systems, and then we continue to meet regularly with our stakeholders to receive continuous improvement and feedback. There are some areas of continued focus. With every managed care launch, there are bumps in the road that we try to smooth. Strengthening relationships with key stakeholders and Healthy Blue Care Together remains an area of continued focus. Prior to the Child and Family Specialty Plan, these children were served by their local management entities, which are very local. Healthy Blue Care Together is a statewide plan, so establishing those local relationships is very important to their overall success, and we continue to put a priority on that. Care management and delivery and performance. Healthy Blue Care Together hired many care managers statewide. Some are also co-located within our county DSSs. We have heard some issues with care management, but Healthy Blue Care Together has reacted immediately, provided additional training, reassigned people where necessary, but that is something we also continue to monitor. Finally, we are looking at, there were a couple of different provider payment issues in the beginning as well. Healthy Blue Care Together was able to issue hardship payments through the months of December and January and February. I have looked, we have not received any requests during February or March to date. So we hope that we're over that hurdle and that provider payments are going out so that services can continue and the providers can continue. And then finally, network adequacy. Healthy Blue Care Together met our network adequacy standards, or we would not have launched. But like with any health plan, we continue to press them to continue to contract with providers statewide so that we can have the most robust network possible for our beneficiaries. And so with that, I'm happy to take questions.
Perfect. Thank you, Deputy Secretary. Before we take questions, I'm going to turn over to Ms. Angela Boykin, the CEO of Healthy Blue, for her perspective.
Thank you so much.
The floor is yours.
Thank you. Good afternoon, chairs and members of the committee. My name is Angela Boykin, and I am the CEO for Healthy Blue. It is my pleasure to come and speak to you today regarding the rollout of Healthy Blue Care Together, what we call North Carolina's Children's and Family Specialty Plan. I would first like to thank the General Assembly and the members who have worked on the creation of this plan. Improving the health and well-being of children and families experiencing the child welfare system is important for our state. And at Blue Cross and Blue Shield of North Carolina, we are honored to be a part of this work. We also want to thank our partners at the North Carolina Department of Health and Human Services for working alongside us to get this plan launched. The goals for the plan are straightforward and they are critically important. First, this is a transition to a statewide plan from the regional system that previously existed. We have launched a single holistic health plan that combines physical and behavioral health for seamless, integrated, and coordinated care. This health plan incorporates the entire family into the process to support reunification. At launch, we enrolled over 32,000 foster youth from birth to 26. This new approach allows us to minimize disruption in care due to movement or placement of children. Next, this plan focuses on the needs of each individual child. You all have a copy via email of our intensive care management model and the services that are outlined by this plan and offered by this plan. Each child who enters our plan is assigned a care manager within 24 hours of enrollment. And as you will see when you take a look at the diagram, a full array of supports begin immediately. As soon as the child enrolls in the plan, the care manager will reach out to the member and a complete risk assessment, which will include a medication review, is done and coordination directly with their primary care provider occurs. Additionally, the care manager will continually evaluate the member's reunification and permanency goals. The single statewide plan allows the child to have a digital backpack of sorts. Wherever the child goes, whether they change placements, are reunified with their family, or need specialized care, all their data is available through our online system. Finally, local collaboration is crucial. Our county partners are essential to this work. This is a statewide plan, but we take a local approach. So we remain responsive to on-the-ground realities of our state's 100 counties. Nearly 80% of the counties have accepted our offer to have a care manager co-located inside their DSS office. Our regionally based DSS liaisons are building trust with the counties we serve, fostering stronger relationships and collaboration on behalf of our members. Our care managers work hand in hand with social workers in every county to ensure our members get the services they need, regardless of where they live. We launched, as you heard, on December 1st, and we are extremely proud of the plan we have built. We took the time to listen. Our plan design is informed by families, local communities, providers, and child-serving organizations. Our approach draws on the deep well of expertise across the state so that we can better serve the population. We are incredibly proud of the team of experts we have hired, many of whom have worked their entire career serving children. Some have left clinical work to be a part of this initiative and bring with them decades of experience caring for children who experience the child welfare system. We've partnered with a robust network of providers across the state as we work to reduce the number of children staying in DSS offices or emergency departments by increasing local access, placement capacity, and stability. Our network includes providers who specialize in care, treatment, and therapeutic services for youth in DSS custody. While we are proud of the work that we have done so far, ongoing progress remains our top priority. We are consistently seeking feedback on our processes to ensure they work for our members. We meet weekly to receive real-time feedback from stakeholders who are in the field caring for or serving this population. We proactively reach out to providers to ensure that billing is done correctly so our provider partners get paid promptly for the care they deliver. This plan is truly remarkable. It's an initiative that was envisioned by this body. However, the challenges we are trying to solve are not going to be solved overnight. It is going to take each of us in this room and many others across the state working together to achieve the child welfare reform we need to see happen. Thank you for your leadership and your time today.
Thank you, Ms. Boykin. I know this has been a very big task, and I think we're glad to see it all finally being rolled out. I'm going to turn it over to the chair for questions on Vice Chair Gailey.
Thank you. Not much of a question, but I went to tour Crossnor as a residential facility for foster children in Winston-Salem. It was really interesting. And just to help me with my mental map of Medicaid and how things relate to one another. As I understand it, the Children and Family Specialty Plan is kind of like a tailored plan, but for a specific subset of children. Is that right? This is mental health treatment and services similar to what adults on a tailored plan may get, but it's more directed toward the needs of a specific subset of children in North Carolina, the foster care children. Is that an accurate statement?
Deputy Secretary Bush.
Yes, Senator Gailey, the services that are provided in a tailored plan are the same services that are offered to children in foster care or children who have aged out of foster care under the CFSP. However, not all children in foster care are tailored plan eligible. So that's really the difference. They just have the array of services.
Okay, follow-up?
Follow-up.
My follow-up question is if this plan is successful, how do we know it? What is the concept for measuring outcomes to show that the approach has had a demonstrable impact?
I'm going to let both Deputy Secretary Bush and Ms. Boykin answer this question. Deputy Secretary Bush.
Thank you. I will start. So our goal is to make sure that children are getting the screenings and healthcare services that they need the minute they come into Medicaid custody, or Medicaid enrollment, not custody. They come into child welfare custody. We are measuring the timeliness of services and screenings. We are measuring the appropriateness of placement, and we are measuring health outcomes for these children. It is not going to solve all problems for child welfare system, but we consider that to be the signal of success is improved health outcomes for these children. but I will defer to Ms. Boykin.
Sure. Ms. Boykin?
Thank you. I agree with Deputy Secretary Bush. I would also say that one of our primary goals too is reunification, to be able to have an opportunity to work with the families and surround the families, and when appropriate, have the children back with their families in a safe environment where they are getting the care and the services that they need.
Thank you. Co-Chair White.
Thank you, Mr. Chair. Thank you so much for your emotion. Having been a nurse that goes into the home and takes the child away and has to go before the judge to bring the child back out, and I totally appreciate that. And thank you all for what you're doing. I do need to have a little description, and Secretary Bush, this may go to you, but I need to understand, I just need a little teeny description of what was happening before we went live with this new program, and what was happening before we went live in the life of a child. If somebody could just tell me what happened in the previous plan that was being implemented by DSSs at the local level, and what is different right now that takes that child from day one to the day that they are released. It maybe have to go back in, but they're released. And you don't have to go a lot of detail, because there's got to be one or two major bullet points that I just need to hear.
Deputy Secretary Bush.
Thank you, Chairman Sawrey. Thank you, Representative White, for that question. So the biggest difference between how it was working before and how it's working now is that it was a regional program. Children were served by their local LME MCOs within that catchment area. Because this population is so mobile and they often are put in placements across the state, providers would have to contract with multiple LME MCOs. There was no one source of health care for these children. So now that we have a statewide plan, Healthy Blue Care Together is able to manage their care across the entire state.
Follow-up.
Can you give me an example of what has happened with Healthy Blue that's different than before? Just one example.
Ms. Boykin.
Thank you, and thank you so much for your empathy. I appreciate that. One example is when a child moves maybe into a placement situation that may require them to be from one county to another county. They have one care manager. That care manager is assigned to them within 24 hours, and we're able to keep all of their records and all of their information together, so it offers consistency and continuity. So regardless of whether the child might be, let's say, in Wake County and moves to maybe Watauga County, they're able to keep all of that information together and consistent, so it's not a start over for the child. It's not additional trauma or confusion for the family that's involved in that. It stays consistent because the record and information stays together.
One more follow-up.
Follow-up, yes.
Can you give me, without the naming of the county or the child, can you give me an actual example?
Yes,
that's actually happened?
Ms. Boykin.
I can't. Thank you. Sorry. Thank you. Yes, I can. We recently had a situation where a child was in DSS custody, and they needed to go into a kinship care for a period of time, but they also had medication and information that needed to travel with them, and we were able to take the care manager and work with the family and make sure that that information was transferred to the next county specifically for that child, and then when they went into the care of their family, all of that information was together.
Before this program, what would have happened?
I think it might have been a disconnect in the information sharing, and maybe not all of the information would have been able to go with the child. A great example that we have is if a child has asthma, their inhaler may not have been moved with them when they move to the next place. And it's not because people didn't want that to happen, it's just the information wasn't necessarily transferring with the child. This way the record is there, and we know that the child needs the inhaler, and we make sure that that occurs and it's with the child when they arrive, or a prescription is ready so that they can pick it up. Thank you.
Chair Potts. Recognize for a question.
Thank you. I have a question. Before we had Healthy Blue, you could cross the river from my county to Representative Howard's, and it may take a couple weeks for the records to get over there. And to be honest, many social workers didn't complain because they could transfer it to somewhere else with their caseload. It would appear that this part of our segment of our population may be one that doesn't have a stable home environment, places where the internet would be always hooked up. What are you doing now? What's Healthy Blue doing that couldn't be or wasn't done before to can make sure there's continuity of service? Because you still have to communicate with them when your appointment is. The 8-year-old or the 12-year-old boy or girl can't drive. They're dependent upon probably their mom and dad if they're there or someone else. What are you doing now that wasn't done before that's going to create a success here?
Ms. Boykin, you're recognized.
Thank you. That is a wonderful question. Part of it is the fact that every child has their own care manager, and that care manager stays with that child. And it's also going to be working with DSS to make sure the information travels from county to county as it needs to. They have a conversation, they have a meeting. We have care managers who are co-located, as I mentioned, but also those that may not be co-located. They live in the counties that they serve. They are local, and so they can go into the office, they can share information and make sure that information is provided from county to county when the child is moved, as you in the example that you gave, if they're crossing over the county line. So we've got those relationships with our care managers and our DSS teams. Additionally, we have a very comprehensive team of people that are focused to make sure that the records are available, that they are updated, that all of the information is provided, and we work every day with all of the DSS offices in North Carolina to ensure they have what they need so that when the child is moved, whether it's kinship or another placement, everything about that child is going to that next provider or to that family. And additionally, I'm really proud to tell you all about something called comfort cases. We know that when children go into DSS custody, often it's in a traumatic situation and they're unable to take everything that they may have had with them or personal things for them. And we make sure in North Carolina that all of the DSS offices, the social workers, and even law enforcement have access to these cases so that the children are able to have their own backpacks, age appropriate, with things like a book, a toothbrush that's just theirs, a new pair of PJs that's just for them, and a blanket so that they can have that comfort when they do move and they can keep it with them.
Thank you, Ms. Boykin. We have time for 2 more questions. Senator Bergen.
I'll be real quick. And first, I want to thank Ms. Boykin. I've talked to her a lot, and I think Blue Cross is doing a great job with this. I've had no complaints from anybody. I still get calls about social services, but and I don't know if you have all this on the top of your head or not, but would you run through the numbers for us? Total number of kids that you all are dealing with, total number of kids that are in hospital or ERs or facilities, total number of kids out of state, so people can realize the magnitude of what we're dealing with, what you're dealing with. Thank you.
Ms. Boykin, you're recognized.
Thank you, and thank you, Senator Bergen, for that question, and also thank you for your support. In total, for the Children and Family Specialty Plan in Healthy Blue Care Together, we have just over 32,000 kids that are enrolled in the program. The other questions that you asked me are very detailed and things that I would like to be able to get back to this body on so that Mike and I can work together on the information, because there are placements that are very individualized and there's information that's very specific and unique to each child, and children do change their placements. What I would like to share with you that I do think is critically important and a part of the answer to your question, we've been very fortunate to reduce the amount of time it takes us to work on a child placement. When we started, it was about 45 days. We have now got that down to 16 days. And so what's incredible about that is we are able to get children placed really quickly. And to your question, we do have children that are out of state and they are in state as well. And due to the detail that we would like to be able to share in the different categories of how placement works, I would be happy to bring back a more detailed report.
Thank you, Ms. Boykin. Representative Crawford, last question.
Thank you, Mr. Chair. And I have 4 questions, but I'll narrow it down to one long question. No, I'm kidding. I do have 4, but I'll only ask one. Thank you for the presentation, and thank you for the work that you all are doing at Healthy Blue. Really appreciate it, and the department's work on this. You mentioned that ongoing progress is a top priority, and that there will be challenges ahead. This is not a problem that we solve overnight. Could you
name the top 3 challenges and maybe the top 3 things that you need us to be thinking about as we continue to support this work.
Ms. Boykin, you're recognized. Thank you for your brevity too, Representative Crawford.
Thank you for the question. Top 3, thank you for acknowledging too, we are not going to do this overnight. And I think the top one is making sure that our care managers are trained and they are ready. We continually train them and make sure that they have the information that they need. As you can imagine, this is a lot of information. It's a very complex thing to take care of these children. And so I would say training of our care managers and making sure right skill set, right fit, and also that they're building those relationships with the county representatives, working at the local level. And I'm a North Carolinian, just in case you can't tell. Working at the local level in North Carolina, it is so important. We just can't do the work unless we're working locally. And so that's critically important. And then I would also say working with providers. We are working with some new providers that are adjusting to how all of this works and spending time with them and helping them know the importance of submitting the claims correctly and making sure that they're successful so that they're paid. That's what I would say. And I would be remiss if I have a minute to say what I need from all of you, and y'all are so great to do this, is just the continued support. This work is so critical to our state, and it's just going to be amazing what we're going to be able to do for these children when we work together. So thank you for that.
Thank you, Ms. Boykin. I appreciate you coming today and presenting to us. All right, with that, we're going to turn it over and talk about Medicaid autism benefits. I'm going to turn the program back over to Secretary.
The primary modality for RBBHT is applied behavioral analysis. So we are going to be using those 2 terms interchangeably for this presentation. So as you heard in the fall, we have seen growth in ABA services utilization nationally. Medicaid agencies across the country are seeing exponential trends in utilization and spending. Nationally, ABA grew almost 300% between 2019 and 2024, although it does vary by state. You can see here is a snapshot. Massachusetts grew by 75% between 2019 and 2023. North Carolina, 347% between 22 and 25. Indiana, 607% between 2017 and 2020. And Nebraska has seen a 2,000% increase between 2020 and 2025. Utilization growth far outpaces increases in diagnoses for ASD. And we've seen recent federal audits that are focused on this service, focused on whether or not the quality of the services received is high, whether it's individualized, if it's the appropriate intensity, duration, and integrity. What's happening here in North Carolina, as I mentioned just now, we have seen it grow by 249%, the number of beneficiaries that are receiving the services. The spending has grown by 347%. The spending growth is concentrated among a small number of providers, but we are seeing a significant influx of new providers into the market. Other drivers are that we think that it might be being utilized when less intensive and less expensive services may be available. We have done some analysis, and we think there's the opportunity for our clinical coverage policy at Medicaid to tighten up the expectations on individualized treatment planning. And we also think that there's ability for the North Carolina Medicaid program to clarify on billing and place of service. So these are things that we are considering moving forward. This is just a snapshot. You can see that we grew from 3,800 recipients in 2022 to 13,000 in 2025. As you can see, children under the age of 6 are the primary recipients. It accounts for about 70% of our expenditures, but depending on the needs of the individual, of course, older children and adults may also need these services. So you can see the spend broken down there. What we see on the bottom is the number of hours per month. You can see that in 2022, the mean number of hours per month was 47.5. That has increased by 2024 to 54.1. The mean, of course, means that there are people making a lot more than that and people making a lot less than that in terms of hours of service per month. So that's just sort of where we are. We're seeing the number of beneficiaries increase, the spending increase, and the number of hours per month increase. So this is a chart that you've seen before. You can see that in 2022 with 3,800 users, we were at about $121.7 million. It increased by 52% the next year in terms of total users, 48% the following year, and then 55% last year. You can also see that the spending is growing exponentially. We are projecting $842.8 million in spend for the current fiscal year. And of course, we project even higher next year, barring any interventions that we hope to take. Other states are doing a number of different things. Like I said, this is not a Medicaid, North Carolina Medicaid specific problem. This is happening throughout the country. We've seen states implement prior authorizations. We've seen them cap the number of hours in a day or a week. We've seen them tighten documentation. We've seen them use assessment results to guide the planning. We have seen some states do rate reductions. And then we've also seen parent participation requirements in the training and in the sessions, and clamping down on the amount of services that are provided telephonically or via telehealth. So last fall, we did our own analysis. We looked at our spending, we looked at our drivers, we gathered feedback, and we issued a white paper in October of last year outlining our drivers and the options that we are planning to pursue. I want to say this is in blue here, but I want to say this and underscore it aloud. We are committed to making sure that the children who need these services continue to receive these services. We just want them to be provided in the amount, scope, and duration that is appropriate for the individual child. And we think that there's opportunity for our policies to tighten up and clarify that. So things that we are also considering is ensuring that treatment plans, like I said, are individualized, requiring certification for registered behavioral technicians, requiring minimum levels of care supervision, requiring appropriate use of telehealth, standard utilization management across all of our health plans, collaborating with DOJ to strengthen our program integrity, and require whole person planning and provide linkages to the full continuum of ASD services, because like I said, right now in North Carolina, it's really limited to ABA services only. We did receive comments on our white paper, as you might imagine. We received 165 written comments. Commenters did emphasize, just like we do, that any final changes should not prevent the children who need these services to get them in the right amount and duration. And so when we do implement these changes, we will prioritize preserving access to medically necessary services while improving quality, ensuring that rural areas are not disadvantaged by changes in telehealth, being completely transparent with the community and impacted stakeholders, and minimizing the administrative burden on families and providers, but also increasing our oversight. So that concludes my presentation.
Thank you, Deputy Secretary. I'm going to start just with a comment and a moment of privilege. This presentation, I think, is the product of a conversation we had last year with what are some of the cost drivers that we're seeing. And I think Senator Bergen hit the nail on the head when he asked you earlier about what are some of the largest cost drivers you're seeing. This is something that really jumped off the page, and I think some of the numbers you showed were updated from a prior presentation, and I just jotted down. It's $1 billion increase in expenditures between 2022 and 2027 projected. That's SCIF money, that's state employee raises, that's public education dollars. You know, dollars aren't infinite. We're making choices with scarcity of resources. So I think it's extremely important that we're very judicious with our dollars and our resources to make sure that the people that need these services are getting them. I mean, the program works, the program is there, but those numbers really jump off the page and are shocking. And I had a chance to meet with one of the LME MCOs yesterday in advance of this meeting, and I was deeply concerned when they told me there's a 127% increase in referrals to the Special Investigative Unit at DHHS just over the past year. There are 133 providers that are currently with SIU with open investigations, and there are 35 credible allegations of fraud referrals under ongoing investigation by MID. it's something that even the Wall Street Journal editorial board felt necessary to address yesterday in an editorial article that I think is very timely. So I do think this is a serious topic, especially as we look at rebased numbers that are going to drive a lot of our budget conversations over the next little bit. But with that being said, I'm going to turn the comments over. Do my chairs have anything? Vice Chair Gailey.
Thank you, Mr. Chairman. My question is for this slide that's in front of us right here. I met with AB, a provider, and they strenuously objected to the projections of the number of children who will be needing these services in the future. That they say that in the Medicaid population, there is an amount of children who are going to need the services, and that, as people become aware of it, more people use it, yes, there's been a upward trajectory, but that it levels off, that there's just not that many children in Medicaid that qualify for services to justify the kind of projections that are on slide number 6 that's on the screen. So what would be your response to that?
Deputy Secretary Bush.
Thank you, Chairman Sawrey. Thank you for that question, Senator Gailey. I think what we are basing our projections on is current utilization. These projections come from Mercer, who is our actuary. They help us set our capitation rates for our plans, and they are basing it off of other states' experience as well. So that's really, until we get actuals, they are projections, but this is what their experience projects.
Follow up.
Just a comment that I think that Senator Sawrey's comments about the choices we have to make as funders, and that if we're going to swallow that the 27 projection is that high, then that means that there are other parts of state government that are not going to get the financial attention that they need. So that's deeply concerning, I think, to a lot of us.
Thank you. Chair Potts.
I must have missed something somewhere in the process. We are talking about children with autism spectrum, aren't we? How do you, through telehealth, 1 hour, 30 minutes, or 30 hours, keep 1 to 5 year olds' attention and have any kind of hope that anybody understands what's being said and what's projected? I would think it would be impractical and impossible to do and get some kind of determination of how successful you are. If you keep me on the phone for 1 to 5 hours, I'm not going to be very good about it.
Chair Potts, we've been here for about an hour and a half. Are you trying to tell me something?
I know you don't have to remind me. I appreciate you doing it. You're hoping that I'm not noticing the clock was changing.
Well, I know you've noticed the clock. You've already looked at me twice. And I do think 2 of our other presenters are going to talk about that. But Deputy Secretary Bush, I'll recognize you.
Thank you, Chairman Sawrey. Yes, I would defer to the clinicians. I am not a clinician, so I could not speak to the appropriateness of telehealth, but I will defer to my colleagues here if they have any more.
Is it okay if we come back to that? Okay, perfect. Chair White.
I just want to thank the department for meeting with us early this morning, and you answered all my questions this morning, and I think we have some ideas about moving forward, so I won't take up the time to restate those, but thank you so much. I think you heard us this morning.
Chair recognizes Representative Ryan.
Thank you, Mr. Chairman. And thank you so much for your work here. Looking back at slide 3, when we're looking at the different states, really different time continuum on each of those. Do we have what that would look like, say, if we took it from 2020 to 2025? And then Indiana, I believe, had an audit in 2019, 2020, where they found $77 million in 1 year in potentially fraudulent payments. What are we doing here in North Carolina to look at that same possibility?
Deputy Secretary Bush, you're recognized.
Thank you, Chairman Sawrey. So there are different time frames for each of these states because states vary on when they actually cover the service. So they may have entered the market sooner than the state of North Carolina, for example. And so these are the time periods that they have seen the market increase. And so that's what that represents up there. In terms of what we are doing, I think we are asking our health plans to use all of the tools that they have to put providers on prepayment review, post-payment review, make referrals to fraud, waste, and abuse to the Office of Compliance and Program Integrity, also to the Medicaid Investigative Unit, where we think that there is inappropriate billing. And that's essentially the tools that we have right now. I did mention that there are some opportunities for us to tighten some definitions and oversight, but that's what's happening today.
Thank you, Representative Ryan. Thank you, Deputy Secretary. Senator Heiss.
Thank you, Mr. Chairman. I really want to get at, and I'll explain why, what are the qualifications of these behavioral technicians / registered behavioral technicians? Every provider that I've talked to in Western North Carolina will mention to me about the shortage of behavioral health professionals and trying to find behavioral health professionals. Given that environment, to see 500% growth is not possible in the services. Even if you had an autism growth rate, which would be astronomical, of 7% a year, 8% a year, you're not scratching the surface of where this is coming from. And I would almost think that these have to be individuals that would probably be someone with no qualifications, with a very short timeline to a qualification, like a course, or sign a piece of paper. I mean, that's kind of what is getting at to me, is what we're providing, because nothing here can answer the question of where this growth rate's coming from, given our current environments.
Deputy Secretary Bush, or Secretary Sangvai.
Thank you, Mr. Chairman. Thank you, Senator, for that question. Again, that might be better answered by the professionals who provide these services. On slide 8, you'll see at the bottom, we have identified that same question on what is the universe of providers, how much service can they actually provide. My understanding is that the BCBA is a board-certified individual who then can supervise individuals who are either registered or not registered. There is a certain amount of training that's required, but those are the type of things that we want to understand. We want to make sure that all the clinicians who are participating in providing ABA services are duly trained, duly certified, able to provide that, and when supervision is required, appropriately supervised.
Let me follow up with just
Follow up, Senator Heiss.
one quick question. How confident are you that these services are even actually being provided?
Secretary Sangvai.
So again, thank you, Mr. Chairman. Thank you, Senator Heiss. Our confidence is based on the fact that we have the managed care companies that have their utilization management capabilities, their ability to review, as well as feedback that we get from patients and families that the services are being provided. There is always the opportunity to understand whether or not they're being provided as intended, but right now we have no reason to believe that the services aren't being provided in the manner in which they're being provided. I think our questions are largely around scope, duration, and the mix of services.
Representative Crawford, you're recognized for a question.
Thank you, Mr. Chair. So just regarding the spike in utilization, I'm curious for North Carolina if the department has made any decisions that are less restrictive that might have caused that spike. Again, trying to think about this compared to other states, if there's anything like that you can identify.
Deputy Secretary Bush, or Secretary Sangvai.
Yes, thank you, Chairman Sawrey, and thank you, Representative Crawford. There was, and I have to pull it off of my phone, I apologize. There was legislation that passed, and this was a question, Representative White, that you had this morning that I said I would have for you this afternoon, and now I am looking for it. Okay, yes. General Statute 90-726 is legislation that established the North Carolina Behavioral Analyst Licensure Board, and it streamlined the path to licensure for board-certified behavioral analysts and allowed them to practice independently without the need for supervision by a licensed psychiatrist or psychologist. And that change did contribute to the number of providers that were entering the market. I also know that There was a 15% increase for services that was supported by the department and the General Assembly that also was probably an incentive for people to join the market.
Thank you, Deputy Secretary. Senator Robinson.
Yes, I had questions along the line of Senator Heiss, but what I'd like to know beyond that is, right here you say require registered behavioral technician certification. So does that mean you don't require it? And if you don't require it, do we have a responsibility to reimburse those providers?
Secretary Sangvai.
Thank you, Mr. Chairman. Thank you, Senator. Again, I can be corrected by those who provide these services, but my understanding is that a board-certified behavioral analyst can supervise behavioral technicians as well as registered behavioral technicians, and so they can supervise both classes of individuals. Currently, we do not require that registration, and it is something that we could look to requiring.
Yeah.
Follow up, Senator Robinson.
Well, no, I think you need to.
Senator Bergen.
Thank you, Mr. Chairman. I guess, Deputy Secretary Bush, this will be for you. Can the department pause services? And I know there's some legislative things we've talked about, but can you all just say this is so out of control, we're going to pause services for a while with new providers or new people coming into the system till we get a handle on this? Because after our conversations, I'm just extremely concerned about the dollars versus the services they're actually getting. And as a lot of it's child care instead of therapeutic care, can you all do that, or do we have to do that?
Deputy Secretary
You
Bush.
can do it. You could stop it. We could pause it now, and then everybody's going to pay attention to it, because when you pause it, everybody's going to want to talk about it.
Deputy Secretary Bush.
Thank you, Chairman Sawrey. Thank you, Senator Bergen, for that question. So right now, ABA services are considered acute care services, and we have contractual and legislative language that says that all acute care services are required to be open network. And that means that any willing Medicaid provider who wants to provide that service and is contracted with the Medicaid program, enrolled in Medicaid, and contracted with a health plan can provide that service. We would need language that would close the network or allow for a closure of the network to limit who is able to provide those services. And so we would need to work with the North Carolina General Assembly to make that happen.
Thank you. I have a question. I'll direct this to you, Deputy Secretary. What level of utilization management or prior authorization are LMEs allowed to do with respect to what services are being received, the amount of services being received, and additional check-ins along the way to see progress that may or may not determine the need for adjustments to whatever the plan is determined?
Thank you, Chairman. Sorry, that's a great question. So we have our clinical coverage policy as the floor. They can be no more restrictive than our clinical coverage policy, but they can implement prior authorizations. They can implement screenings of providers. They can implement prepayment and post-payment review, which we've already talked about, for anyone that they think is billing inappropriately. Those are the tools that they have in their toolbox. They pay the claims. We actually don't receive their encounters until after they've been paid, so there's a little bit of a lag before we see it. They're seeing it frontline, and they should be managing that service appropriately. I think one of the complicating things about this particular service is that it's for children, and people do not want to limit access to services for children, especially children with autism spectrum disorder diagnosis. And we do have a federal law, a requirement that you have to provide any services to ameliorate a condition under early periodic screening, diagnosis, and treatment, EPSDT. And so I think that some plans may feel sort of boxed in by that requirement as well, that they can't put limits on this service, but they absolutely have the ability to do that.
Representative Cunningham.
Thank you, Mr. Chair. Deputy Secretary, you said you all go ahead and pay the claim. How long after you pay the claim, if there is an investigation, do you have the authority to recoup?
Deputy Secretary Bush.
Thank you. So we don't pay the claims, our health plans pay the claims. We receive encounters that show what they're actually paying for. Depending on the investigation, will depend on how long we can recoup, but generally if it is found that there's fraud, waste, and abuse or some sort of criminal fraud involved, that's subject to the courts, and I am not an attorney, but we generally do have the ability to recoup those funds, and then we return the federal share to the federal government, and we turn the state share to the general fund.
One,
Follow up.
Mr. Chair. So you don't have a time frame when you can recoup. It could be a year, it could be 2 years, it could be 3 years, but the money's already out. Thank you.
All right, Deputy Secretary, thank you. I'm going to move on to the next part of our part 5 of this agenda and turn over to Kerri from the Autism Society to talk about patient and parent perspective. And you also have some guests with you today, so I'll let you introduce them as part of your program. And I will turn over to you. Thank you for being here.
Okay. Thank you, Senator Sawrey, and thank you, committee members. We are so pleased to be here. Thank you for your service to the state and your focus on this important service for our kids with autism across the state. I'm Kerri. I'm our Chief Program and Policy Officer. I have been with the organization nearly 25 years. Clearly, I began when I was 10 years old. So I've seen some things here in North Carolina over the years and appreciate our attention to maintaining quality access to this service so that it's available in the future. I have Whitney Sukonick with us, who is our clinical director, and Meredith McCumbee, who is a parent from New Hanover County. Given the time, we're going to yield our entire time to Meredith, and we'll be available for questions afterwards or for more information as needed, but I know that we're trying to get caught on the agenda, and I definitely want you guys to hear from our colleagues as well.
Thank you, Kerri, and thanks for having me today. My name is Meredith McCumbee, and my husband and I live in New Hanover County with our now 18-year-old daughter, who's here with me today, and our 16-year-old son, Aaron. I'm not here as a clinician or an academic expert. I'm here as a mom who's juggling a very different parenting journey to support a big sister and a little brother with different parenting needs. I'm here as a wife, and I'm here as someone whose family has been profoundly impacted by having access to quality ABA services. When people talk about ABA, we often talk about treatment plans. We talk about measurable goals. We talk about data collection. And those things, they absolutely do matter. But what I want to share with you today is what those goals look like inside a real life, inside a home, inside a sibling relationship, and inside a family. At the core, ABA is about increasing functional communication, building independence, teaching social skills, reducing behaviors that interfere with learning and relationships, and truly helping to unlock an individual's potential. For our son, that started with him finding his voice. For years, communication was one of his greatest barriers. Aaron had so much inside of him, thoughts, preferences, humor, so much to say, but limited expressive speech and ways to communicate. Aaron's inability to communicate led to meltdowns, aggression, withdrawal. ABA, in close partnership with our speech therapy, has changed his trajectory. Together, his ABA team and speech therapists focused on building functional communication, not just labeling objects or answering scripted questions, but teaching him to advocate for himself, to request help, to say no, to express his feelings, to make choices, to comment, and be fully present. They worked side by side to support the use of a voice output device, and I brought one of them today so that you could see that. Not just in therapy, not just at home, but across all settings, at school, in the community, with peers, with us. Something pretty remarkable happened. He didn't just learn to use that device, he wanted to use that device. And for the first time, we started to hear his thoughts. We saw his humor come through. We watched him tell his big sister to stop bothering him, most of the time appropriately. We started to see them learn more about each other. We saw a true sibling relationship start to uncover versus them just existing together. We watched him tell us how proud he was of himself. We watched him advocate with family and friends. You see, communication didn't just reduce his frustration, it revealed who he was and his personality. As his communication began to increase, his behaviors significantly decreased. It's one of the core goals of ABA, to replace behaviors that interfere with learning and relationships with functional and meaningful skills. Those ripple effects for us were profound. Before ABA, our home felt like crisis management. Parenting revolved around anticipating triggers and preventing escalations. Our daughter walked on eggshells and was scared. We couldn't leave the children in the same room together for years. When we started ABA therapy, many times it took 4 adults working together to keep my son safe. My husband and I were exhausted. We were always in reactive mode, and it was a struggle, an absolute struggle to balance parenting, working full-time, maintaining relationships with family and friends. We needed help, and he needed help. A quick search brought me to the figure that divorce rates for families with autism as high as 80 to 87%. I can certainly understand why. Marriages strain under chronic stress, not because of lack of love, but because of lack of support and pure exhaustion. My husband and I have been there, and we've felt that. ABA didn't just change our son and our son's behavior, it changed our entire family dynamic. We learned together to reinforce positive behaviors consistently. We learned to respond calmly and effectively. We learned how to set expectations for him that were fair and achievable. Aaron learned coping strategies. He learned flexibility. He learned how to recover. Most of all, he learned that his voice matters. Over years of ABA support, our home shifted from survival mode to growth mode. Our kids' relationship transformed. Where there was once tension and unpredictability, there's now shared laughter. They have inside jokes. They negotiate. They play games. They argue like typical siblings, and then they recover. ABA helped to rebuild their relationship by giving Aaron the tools to regulate and to communicate. Friendships have followed a similar pattern. As behaviors and communication increased, or as behaviors decreased and communication increased, peers were able to see him for who he is and not just his challenges. Today, Aaron contributes to household chores. He follows routines. He manages parts of his own schedule. He completes tasks from start to finish with varying levels of prompting required. And these are not small victories because independence builds confidence. Perhaps most meaningful of all, Aaron has found himself. When challenging behaviors dominated, it was so easy for people to define Aaron by what he struggled with. Now, everyone can see his humor. They can see his empathy. They can see his determination, his kindness, but most of all, they can see his love for life, and he shines. ABA didn't change who he is. It gave him access to who he already was. Funding decisions can feel abstract, line items, service codes, budget allocations, but for families like ours, access to ABA was a difference between isolation and inclusion, crisis and stability, marriage and divorce. ABA helped us strengthen all of those things. It focused on building independence and skill building for Aaron and promoted dignity with his communication. ABA, most importantly, gives individuals the tools that they need to be able to participate fully in life. My son now uses his voice output device in any setting because he knows that his voice matters. He advocates for himself. He's built so many friendships. He contributes at our home. His challenging behaviors have decreased significantly, and our family is absolutely stronger as a result. When you consider funding services, I ask you to see the whole picture and think of the hundreds, the thousands of families just like ours that are on the receiving end of amazing services when ABA is implemented with fidelity. Thank you for the work that you do, and thank you for having me here today and allowing for me to share our story.
Do you want to show a picture? It's at the very end. You can flip through it first photo. Yes. Thank you, Meredith, for telling the story that is reflective of thousands of families across the state. And we, as an organization, through our support groups, through our direct services, through our autism resource specialists, talk to thousands and thousands of families, so we consider ourselves a bit of a translator. But Meredith really just spoke to so many. So thank you for your time.
Thank you for that presentation. I really appreciate you coming and speaking today. And I thought it was a very important perspective to hear. I think from a parent or somebody who's benefited from this program. I think that's why it's important that we get this right candidly at the state level, so that it's there for people who need it and can benefit from it, and sustainable. With that being said, are there any questions from the committee? Representative Chair White. Chair White, do you have a question? Okay, yeah. I believe she has a question for Whitney.
Hi. I just wanted to thank you so much for sharing your story with us, and I'm so thankful that your son is being able to be your son fully. I do have a question about how many hours. Could you give me an average of the number of hours from beginning to end, not end, but beginning of this program that was provided to this family? And could you also share some of was it on-site with the parents in the home? Was it telehealth? Could you give us a little bit of a program model that was used for this particular family?
Sure, and thank you for your question. So we worked with Aaron. The duration of services and the dosage did fluctuate over the years based on need, but the average was around 10 hours per week. We did work with Aaron in his home and in his community. There were no telehealth services provided.
Thank you.
Senator Heiss, you're recognized for a question.
So, and I think this question may be towards the mother and kind of but in a similar line, do you, and maybe the provider, do you have a sense of what the qualifications were of the person who is providing services? And I guess the question I want more directly to you, how much were you there to be involved in those services and in that education, and what services did you receive that kind of helped in this process?
Thank you for your question. So, wow, we were there pretty much the entire time that services were being delivered. When services were being delivered, it was an educational opportunity for us as well. I think raising a child with different needs doesn't come with a handbook. And what I felt like was that we received that handbook in little chunks throughout the duration of the services that were provided. From the kind of expertise or the credentials of the people providing those services, it was a registered behavior technician and a board certified behavior analyst that was overseeing really, really detailed protocol to support Aaron and our family over multiple years with, as Whitney said, varying levels of hours per week based on need. And I think that was one of the things that we appreciated most as a family, is that when things spiked, we had access to more support, and we needed it in reality.
And just to follow up, put a point on that, do you believe that both of those elements, the qualification, the individual providing, and the participation of you and the family, are requirements for a successful program?
I absolutely do. Yes.
Representative Crawford, do you have a question?
Possibly, yes. A comment for sure and a question. First, thank you so much for sharing your story with us. Critically important, as you've heard from others in here. I think, what we are trying to wrap our arms around is how do we protect these critical services for the folks who need it most and ensure that what we are able to provide as a sustainable program going forward. So, one question I have, I guess is, how do we do that? I don't think we're going to answer that completely today. But the question that I do want to know, and this might be a question for the department, is the number of children that are on the wait list with autism that may be needing or getting these services.
Deputy Secretary, do you have that information?
Thank you. I can try to get that information. I feel like we've had this question before, and we do not capture diagnoses of people on the wait list. But I will check with our team and confirm.
Senator Bergen, do you have a question?
Very quickly, Meredith, tell me, how old was your son? How old was Aaron when he was diagnosed? And tell me how intensive the work was with him early. And how old is he now?
He's 16 now.
He's 16. Tell me what services are ongoing, because where we're trying to look at is how quick the diagnosis is, how quick we get services to make the biggest impact. Can you just walk us quickly through that?
Absolutely. Yes, thank you for your question. So my son was diagnosed with autism when he was 4.5. And he started receiving services through the Autism Society of North Carolina shortly after. That autism diagnosis opened up new services for us that we desperately needed within our family from a support perspective. Aaron received ABA services from the time he was around 5.5, 6 years old, and for, again, varying levels of kind of push in, scale up, scale down as needed. The really critical time for us was between the ages of 6 and 9 for Aaron. Those were the point in times where his frustration level and his inability to communicate, really, the behaviors were intense. It was challenging. We couldn't maintain things at home with just the two of us. And we had zero support to be able to kind of work through that and understand what we needed to do differently from a parenting perspective as well. So that was really our critical time from a behavior support perspective. We've kind of gotten over that hump, thankfully, and I think we're on, I won't say the other side, because I think challenges come with every season of life that we've seen. So, we are thankful to have the support from the Autism Society when things come up, that we reach out, and we truly see the Autism Society as our lifeline for support.
Thank you. We're going to move on just for the sake of time. I do want to say thank you so much for sharing your story today. I really appreciate it, and I'm thank you. I know that took a lot. I appreciate you answering our questions as well. With that, I am going to turn over the presentation. We have two providers here with us today, Matt Filer from Mosaic Pediatric Therapy and Keith Labs from Kind Behavioral Health. And I'm going to turn it over to Matt first, if that's okay. Thank you for being here today.
Thank you to the chairs for the invitation to speak. Thank you to the committee members. A special thanks to Meredith for sharing Aaron's story with us. Really appreciate you being here. My name is Matt Filer. I'm the CEO of Mosaic Pediatric Therapy. We are a Charlotte-based provider of applied behavior analysis services to children with autism across the state. I'm joined today by Keith Labs, who is the CEO of Kind Behavioral Health, a triangle-based provider of ABA services also serving children across the state. Both of our organizations began serving Medicaid in 2015 when the RB-BHT benefit was first created. And at that time, we were two of just a handful of providers in the state. We were invited here today to talk to you about what quality looks like in ABA. We'll define those attributes for you today, and we'll talk about how high quality providers approach those. And we'll contrast that with some of the other approaches that we see in states in lower quality models. And as we walk through those comparisons, I think what will become evident are real concrete and actionable steps that will emerge as actions North Carolina can take today that would meaningfully improve the overall quality of ABA services in our state, while also significantly reducing costs. These are wins for children and their families, and they're wins for our state's fiscal bottom line. Today we'll start with a brief overview of ABA. Now, I think you've heard from several speakers already on sort of the nature of the service, but I think we'll be able to answer several of the questions that the committee has had around the delivery model and some of the aspects of how treatment is planned. We'll also then move on to talk about these attributes of high versus low quality ABA providers. And then finally, we'll conclude with an overview of the most effective levers from our view that can be pulled to reduce cost while at the same time meaningfully improving quality. But before we start, you would be right to ask who we are and what our qualifications are to talk about quality. Kind and Mosaic both employ very similar clinical models that keep the patient's needs first. There's a lot that underlies that statement, but the results of that approach speak for themselves. This chart shows Mosaic patient outcomes compared to an industry benchmark along a measure called the Autism Impact Measure, or AIM. The AIM is a scientifically validated tool for measuring the change in a child's autism symptoms over time during ABA treatment. The tool assesses symptoms over domains such as communication, social reciprocity, and atypical behavior. And along these attributes, Mosaic patients realize better outcomes to the tune of 45% to 100% better than the benchmark at 6 months, and 100% to nearly 400% better at 12 months. This chart tells us two things. One, provider quality matters. And two, by virtue of where this benchmark is, there is a lot of variation in the quality of providers that are in this space. So this page provides an overview of two different aspects of ABA treatment, and I'm going to start just on the left. I know there is a lot here, but I'll talk through the main themes. ABA services are delivered through a tiered model. You've heard some discussion today already of a position called a board certified behavior analyst. That's the blue box at the top of this diagram. And then below that is the registered behavior technician or behavior technician. I'll start with BCBAs. So BCBAs are licensed, nationally accredited masters or PhD holders who are responsible for assessing the child's clinical needs, developing a treatment plan to meet those needs, and then overseeing the delivery of care to ensure that the child is progressing according to the plan. They also supervise that next level of clinician, the registered behavior technician or RBT. RBTs are high school or college educated paraprofessionals who receive standardized training and then must sit for and pass a national board exam. RBTs work one-on-one with the patient to execute the BCBA's treatment plan. So again, BCBAs assess and create and monitor a treatment plan, and the RBT delivers care day to day. This concept of supervision, this relationship between these two providers and this dynamic is critical. And it's a major factor in the quality of the service. In a moment, Keith will talk more about how the approaches to supervision can vary between high and low quality providers. So that's the clinical delivery model. We'll pivot now to the right side of the screen just to talk a little bit more about treatment plans, because I know we just had some questions on that topic. This is a 2x2, but what it tries to do is explain treatment plans along two different dimensions. The first of those is the breadth or scope of what the treatment plan intends to accomplish, the number of skills that will be taught, the number of behaviors that will be addressed, and those can either be comprehensive and broad or they can be focused and narrow. And then the second dimension, it relates to the intensity of the treatment program. So intensity can be low, and we typically measure this in the number of RBT hours delivered per week, or it can be high. And so there are kind of four different, versions of treatment plans here. I will say this is a framework. and that a key tenet of ABA is individualization. Every program should be highly individualized. I know you heard the department speak about this as well, but highly individualized to the patient's need. But this is sort of an archetype to understand how these treatment plans work. Just a few examples. In the top right, we have a high-intensity, comprehensive scope treatment plan. These are plans that generally target a wide array of goals and skills, are high intensity, so somewhere between 30 and 40 hours a week. And this is what all of the research over 5 decades tells us is necessary for children that are especially in early intervention programs to maintain or make the most progress. Moving just one more example down to the bottom right, to contrast, a high intensity but focused scope would be a slightly lower number of hours, but really the key differentiator is that they're targeting a much narrower set of treatment goals. Oftentimes these are focused on severe, risky or interfering behaviors. With that, I'm going to pass it to Keith to talk about our next agenda item to get into the attributes of high and low quality providers.
Thank you all for having us here today. We wanted to take some time really highlighting what quality looks like in this industry. As quality is what's going to drive the outcomes. Quality is what is getting the health benefits, the family benefits. It really comes back to, are we spending our dollars well as we're thinking about these kind of services? So I want to start with, there's 3 main things. As you look across providers have different models, but 3 main things that are consistent across models that have high impact and are driving efficient and strong outcomes. The first, as Matt mentioned, is the treatment program design. These are highly individualized, and the number of hours per week, the number of skills and goals that you're focusing on, the location of those services, they're all individualized in how you're thinking about that for that specific patient, that specific client. Secondly, the direct treatment. This is that frontline technician who's providing those services. It should be done by a registered behavior technician. It should be done in person. As you'd expect, very few of these services can be done over telehealth. If you've got a 3-year-old who you're trying to teach how to communicate, they're not going to sit in one place. If you're working with a 14-year-old who may have aggression or self-injury behaviors, you need to be there in person. It's very rare that this direct service can be done via telehealth. When you think about the supervision, this is a piece, as Matt highlighted, this is probably the most impactful lever for the quality of these services. And this is where we'll focus a lot of our time today. But if you have case supervision that's too low or that's done via telehealth, you're losing the effectiveness of that supervision, and we'll talk a little bit more about that. But the first just contrast, as you look at the second piece here, is we're seeing models, an increasing number of models as we go into this industry, and this industry grows, where there's little individualization. Every client that comes into a provider is getting a similar recommendation, the same set of goals. It's not tailored to, do they have 2 other diagnoses? Do they have specific communication needs? Do they have specific unique elements that should impact the intensity, that should impact the goals, should impact the setting? There's providers that aren't using registered behavior technicians. The 3 providers that you're hearing from today all are striving to have registered behavior technicians because it sets a standard that ensures that we're delivering those services in an efficient and high fidelity way. And you also then see increasingly low supervision rates. Oftentimes this can be 2 or 3%, which may mean that frontline technician is only coming into contact with that BCBA, sometimes on a monthly basis. You're doing 40 hours a week of one-on-one care by a paraprofessional who's only overseen maybe once a month. That's an issue. I wouldn't allow it for my child. And then doing that via telehealth. We'll talk a little bit about this on appropriate, where you can use telehealth appropriately, or full telehealth models where it then can get, the model can start to break. So we'll spend a minute just talking about these 2 pieces in particular. So the first one here is on case supervision. It's delivered via a tiered model. The frontline staff, as in most of healthcare frontline staff, has moderate to high turnover and the experience that they're able to bring to the table. BCBAs are the only ones that are allowed to create a program, modify a program, and then drive that parent training. So it means you need sufficient levels of that BCBA being involved to truly try to drive the efficient gains. When you're also working with a 2 or a 3-year-old, as you would hope, when a program is going well, their skills and are progressing very quickly. So you rapidly need to continue to update that program to a new set of skills so that we're working on the right next thing the next week. And so you need regular and sufficient duration of your BCBA supervision to be able to make that effective. The problem right now that we face is there's a financial incentive for providers to reduce their supervision. Their fixed costs or their costs are tied to their BCBA. And so if they lower their supervision, it allows them to serve more kids, but with a lower supervision for every single individual patient that they're serving. The patients lose there, Medicaid loses there, you're spending more money in the short term, and you're losing in the long term because they're not getting the health outcomes that you're expecting from these services. This is a place where we're raising our hand and saying, this is where the department, this is where the legislator needs to help support and add some guidelines around how do we make sure there's minimum levels of supervision to ensure that that adequate supervision is there. As also discussed, the in-person versus telehealth portion of our services is critical. As Representative Potts called out, doing something via telehealth through a computer is materially challenging. So I'll just give one example here. We have, this was a real example from Kind. We had an individual that we were serving in the home. As we're doing services in the home, we were seeing what we call risky or interfering behaviors. This may be self-injury, this may be aggression, or property destruction. We were trying to figure out what was driving that behavior. And as the BCBA was able to go on site, they're able to then realize that the house next door, construction had started. And every time that there was noise from construction or banging sounds, we then had an increase in behaviors that was triggering that. If that BCBA is not on site in person, no one would have seen that, and you would have come up with a completely different modification to your treatment plan without having that real-time observation with someone on site. And we're not here to say that the use of telehealth doesn't have some role here. There are rural communities, there are times when a BCBA needs to be able to connect in with that frontline staff and they can't be there in a real-time moment. But 100% telehealth model makes it so that we need to be thoughtful around it's materially less effective. We need to take that into consideration when we think about guardrails and where we may still want to allow it to make sure that we're not hurting access, but we need to be thoughtful on its use as a part of a total program. The last piece we wanted to hit on is the costs. The costs are going up. In a lot of ways, this is expected. This is a benefit that was just added 11 years ago. Independent practice by clinicians just started just a few years ago. And so there's a massive, massive increase in demand in services. So the actual increase in diagnoses over the past 10 years is one piece that may be driving this, but there's a catch-up in terms of supply with demand. So what we're seeing is a catch-up in that supply and demand, but as highlighted by the department, there's a variety of things that also look interesting as you dig into it, that there are real issues, and we're raising our hand saying, there are more guardrails we should have. We should make sure that we're spending the money thoughtfully. There are great ROIs, financial returns on this investment. It helps to reduce the number of people who in adulthood may need waivers. There's a good justification for this, but we need to make sure we're getting that ROI, and that's through ensuring that we are getting the quality of services that we're looking for. And so as we look across the country, there's a variety of things, and the department had highlighted some of these where other states have started to look into things. What we would pose is there's a variety of things that don't work. Our caps on per week or per lifetime, step up or fail first approaches, things that are not evidence-based that is pushed in utilization management, these don't actually support the best outcomes for the families we're trying to serve, and they often don't result in the savings for the department and face real legal challenges. There are states that are out and have added requirements that push quality-focused measures, requiring supervision minimums, having common sense telehealth guardrails, having enhanced rates for high acuity or higher cost to serve. If you have a patient that you're trying to serve that has high levels of aggression or self-injurious behaviors, it is more expensive to serve that member because you need specially trained team members to support them. But right now, there's not an efficient path for providers to be able to get access to them. And so that is a part of our autism community that is particularly underserved. We also should have audits that are thoughtfully thinking and digging into the quality, not just focused on technical documentation, which should continue to be a part of our audits, but we should be thinking about the quality of the services that are being provided. And so those health plans can then thoughtfully think about where to put their resources and not necessarily spreading them equally across everyone. We'd be happy to raise our hand and say, come look at our services. But as we've heard from the health plans ourselves, they're limited on the resources they have. And there's thoughtful ways to look at the data to think about how they can invest and make sure that this is a win-win, where we're looking at quality, we're promoting quality that will save costs in the short term and materially save costs in the long term. Thank you all for having us here today.
Thank you, Matt and Keith, for being here today. I really appreciate it. I do want to just echo kind of the theme about this whole presentation today is that, we're seeing incredible cost overruns, a larger and larger part of the Medicaid budget being spent on this, but the therapy does work, and we want to make sure it's sustainable so that we have the results that we heard about just a second ago. So thank you for your presentation. It's probably the most detailed presentation I've seen from a provider in this Oversight Committee room in the 3 years that I've been here. So I appreciate you having constructive solutions to it. I have two questions. Might be to you, might be to Deputy Secretary Bush. I'm not sure. Of the total spend or the total encounters that you're seeing with ABA therapy, what percentage of those in North Carolina are via telehealth?
Thank you for that question, Chairman Sawrey. We are doing a data pool right now. Originally, we did a data pool and we were seeing about 10% was done by telehealth. But then it became clear to us that perhaps we were missing some codes, so we are rerunning that, and I'm happy to share that with the committee once we have that.
Sure, I can speak kind of from the, can you guys hear me?
Sure.
From the provider perspective. What is challenging from a claims analysis standpoint and there's a modifier that gets attached to claims that says this was delivered via telehealth, is this supervision dynamic. So while the BCBA code may come into the claims data and have that modifier and show up as such, that BCBA is supervising a technician who is in the home receiving telehealth supervision, but because they are in person, that claim may have been billed as an in-person encounter. What we do know is out of the 3,500 or so licensed behavior analysts in the state of North Carolina, 47% of them do not live in North Carolina.
I'm gonna recognize myself for a follow-up on that. Is it fair to say that that's 47% are performing those services via telehealth?
Yes, sir. Generally, I think that's true. Now, one minor caveat is we may have a neighbor in Rock Hill that's commuting up into Charlotte, and maybe some on the border of North Carolina, but I think we'd be safe to say those are edge cases, and we've seen the data on where these BCBAs live, and they are nowhere near us.
Thank you. Chairman Potts. Representative White.
Now you can understand why when we received this information early this morning, that we're sitting here glaring at you all.
Thank you, Chair.
Not accusing you, just learning, listening and learning.
Thank you, Chair White. Matt, do you have a comment?
Just really quick, what I'll say is Keith and I's organization both deliver far less than 1% of all of our service via telehealth, and it's the family training component, which is very much appropriate for telehealth.
Thank you. Senator Heiss.
Yeah, I wanted to ask this question from the two of you, recognizing you as established providers in the largest communities kind of we seem to have in North Carolina in this service area, who Transit is doing it well. And we've seen, if I took the 22 to 26 time period, astronomical growth rates. What growth rate have you seen in your companies in providing these services? Because I understand that access to services wasn't what it needed to be and those kind of things. I'm just trying to get to what a quality expected growth rate should be looking at those.
Matt or Keith?
Yeah, so I think we saw that there was 300% overall growth rate. I joined Kind in 2018, and we had 3 locations. We have 19 now. We've probably grown somewhere between 25 and 35% a year. We're not growing at hundreds of percent per year. And while Mosaic and Kind were probably 2 of the largest providers 5 years ago, I know I'm not in the top 5. I don't know about Mosaic, but we're, call it rapidly dropping in terms of, while still growing fairly quickly, we're quickly dropping in terms of kind of the overall size, percentage of the market.
Senator Bergen, recognized for a question.
Yes, sir, real quickly. So I understand that a RBT, a registered behavioral technician or whatever you call it, only has to have a high school education and 40 hours of training, and then they can work hand in hand with a patient, right? With a child or anybody. Is that correct?
Matt, you're recognized.
Thank you. That is correct. The RBBHT manual today says that there's a 40-hour training requirement that aligns with the Behavior Analyst Certification Board requirement of 40 hours, but it does not require the registered designation through a test. That's correct.
Follow up for Senator Bergen. So would your all's recommendation from you two, and Keith and I talked at length a couple of weeks ago about this, would you all recommend that we do something about that and the people that are benefiting? And then also, would you both tell me on average how many hours a week you provide services to clients? Thank you.
Matt, you want to take the first stab at it?
Happy to. So the answer to your question, Senator Bergen, is yes, we would recommend that we do something about it. There is one important consideration as we think about a requirement for behavior technicians to become registered behavior technicians, and that is that most people, to the tune of 95%, that are hired as a behavior technician have never worked in this field before. And that's really a result of the fact that the service is still emerging and that there isn't a base of qualified existing registered behavior technicians. I'll also note that the RBT position is generally not a career. It is a stepping stone to another career in healthcare, human services, education, and so turnover rates among RBTs are high. Every year, the industry is replacing, depending on the organization, between 50 and 100% of their behavior technicians. And so what that means is we need to apply a rolling grace period to that attainment requirement, meaning from the moment a technician starts at a company, we would recommend that they have 120 days to obtain their registered credential. And the reason that that is important is the process to do so takes a full 120 days oftentimes. There's the training they must go through. They have to register to take the exam. Exam wait times can be between 1 and 2 months because of availability. And then there's a question on credentialing, which extends that timeline further. So without a rolling grace period, we would create the biggest barrier to access that I can think of in terms of the changes we might make. But we are in favor of requiring it, and we also are in favor of ensuring before a technician serves a single Medicaid beneficiary that they have done the 40-hour training and passed the competency exam, and it's documented so that we know that they're proficient and competent in what they do. So we get the best of both worlds without dramatically impairing access.
Senator Adcock, recognized for a question. I'm sorry, did you have a follow-up comment?
There was a second part to the question I didn't answer, I apologize.
Average?
Yes, sir.
Average of HO.
For us on average, our clients are getting 25 hours a week, but when you look at the distribution, it is a normal distribution, meaning there are just as many that get a little bit more as there are that get less. That's correct.
Thank you, Matt. Senator Adcock.
Yes, thank you so much, Mr. Chair, and thank y'all so much. Your last answer was a very robust answer to Senator Bergen. My question is about the supervision. When you say greater than 10%, and I looked at your graphic, and there was 1 behavioral therapist and 9, so I need to know, is that how the composition composition of the team, the treatment team, is that the amount of time that the ABA therapist actually spends supervising a particular case? Is there a case limit? Is that supervision on-site versus telehealth? You get my drift. What does that supervision look like?
Keith, you recognized.
So that would be a percentage of hours. And so there are generally accepted standards that supervision should typically be between 10 to 20% of direct services. And so we would look at this in terms of billed hours, so something that is very easily looked at by health plans, where you would look at the BCBA services. This is their plan of care writing, their parent training, their ongoing supervision. You'd add those up. That would be the numerator, and the denominator would be the frontline direct services done by that RBT. And so it would be 10%. So effectively 1 hour for every 10 hours of frontline supervision, which then can be done 1 day a week or can be split into 2 short times a week. And so different models may make sense to do different things based on that individual child, but it's 1/10 of the services. So it's not per people in that everyone may not be full-time or part-time, but it is per number of hours delivered.
Senator Adcox recognized for a follow-up.
Very quick follow-up. And is that quality-focused supervision? Is that on site? Tell me, is that how it always is? If it's high-quality supervision?
Keith, you recognized.
Ideally, that is done on site. In an ideal world, that is done on site. There are times where either in a rural setting or even in a different setting, if services may be most efficiently done in a home, on a Thursday when the RBT, the BCBA may have been there on Monday to do their typical supervision. On Thursday, there are behaviors that are then showing up, and the RBT may say, hey, can you do a short, brief supervision? But they live an hour away, so the BCBA can't get out there. And so where doing some supervision via telehealth can still make sense and be supportive. I would think that you would want that as close to 100% as possible. It is. We do most of our services in clinic partially so that we can ensure that we can do that supervision live and in person and be available. But there are scenarios where, especially in more rural communities, where services are done in home and where the use of supervision may need to be used or it would have more material impact on access.
One more follow-up.
So what you're saying is some mix might be good, would be acceptable, both telehealth and on-site, but it certainly shouldn't be 100% telehealth supervision.
Yes.
Representative Cunningham.
Thank you, Mr. Chair. I got 3 questions real quick, though. What would be the out-of-pocket cost if they didn't have Medicaid? And I guess one in kind, you all make an answer. What would that cost for the RBT? And what would it cost for the BT? The hourly rate. If they didn't have Medicaid, if it was a private pay, what would be the cost?
Matter, Keith.
Sure. The honest answer is I'm not sure because so little ABA therapy is provided on a private pay basis, if I'm understanding the question correctly, because it is a very intensive service. Even very wealthy individuals, would struggle to cover the full amount. So I just don't know.
Mr. Chair.
Follow-up, you're recognized.
Thank you, Mr. Chair. On the capturing, I guess this goes back to Deputy Secretary Bush. Do the LME or the MCO supposed to capture when they pick up autistic children? And you all don't capture it, but aren't they capturing it, especially if they receive an innovation waiver services? They may not have a slot, but they're getting some services.
Deputy Secretary Bush, you're recognized.
Thank you. Thank you for the opportunity to clarify, because I have since received a text message and a handwritten note that says that we do capture diagnosis. It is available on our Innovations Waiver dashboard. We can share that link with you. It is on the DHHS website, and so you should be able to see that.
Last follow-up, Mr. Chair. Can we find out how many children specifically are receiving the services? Because from looking at 40 hours that they can be given treatment, 40 hours all is required, and you're saying it's a stepping stone. We're probably infiltrated with a lot of these individuals that can provide services now and with the demand. But I'm also concerned that we're flooding the space And we may not be getting quality improvement and outcomes, but we just got people doing services and services. And I think we're gonna have to look at some options. You may be doing it right, but a whole lot of other people may not be doing it right. Thank you, Mr. Chair.
Thank you. With that said, I took the 30 minutes that Chair Potts gave me this morning. We have gone over. I deeply appreciate presentations from Matt and Keith. Thank you so much for talking and giving some constructive recommendations. Thank you to the Autism Society for being here today and sharing your story. I really appreciate that. Thank you to DHHS Secretary Sangvai, Deputy Secretary Bush on talking about this. Again, we want to make sure we get this topic right. ABA or BBHT therapy provides a real benefit, as we've heard, but at the same time, we're seeing the cost increase year over year over year. There's a solution, a path forward. I'm hopeful that we can work together and we can make sure it's sustainable for the taxpayers, for the patients, and for the provider community. With that being said, we're adjourned. Thank you so much for being here today.